Thank you everybody for coming. My name's Lara McLaughlin and I work as part of the Mid-East Toronto sub-region team. And we've been working welcome, just have a seat, on the topic of really strengthening discharges from hospital to the community. And there's been a working group that has come together representing hospital, shelter drop-in and respites, and community services, who have put together this workshop series. This is the first of 5 workshops taking place this fall, and we've called the series the Community Hospital Homeless Health Education and Learning Series. It's a lot. And this is the Capacity Assessments and Consents workshop. And our speakers today are Nicole Schroeder and Dr. Mark Lachmann. Great, so the first 40 minutes or so, we're gonna go over the content. We're gonna look at informed consent and the legal framework for consent. What is capacity and the legislation that determines it? Definitions and responsibilities relating to decision-making on financial capacity and psychiatric treatment. Then we'll spend 20 minutes looking at 3 case studies, some of which were shared from community organizations. And then there'll be 30 minutes for a Q&A. So if you have other case studies from your own practice, you can share them then and get the input from Nicole and Dr. Lachmann about what some appropriate pathways may be for some of the cases that you're working with. The purpose of this session is really to build knowledge of frontline workers and supervisors on this topic of capacity assessments, what they are, and how to access them. We had thought to cover long-term care as well in this session, but we realized as we were putting this together that there was enough to go over just with these 2 particular pieces of the capacity assessments question. And so we're likely to be offering the long-term care assessment workshop later on this fall, and we'll let you know about that. It'll just focus on long-term care specifically. Okay, so pass it over to Nicole. Sure.
Thank you. Hi, everyone. I recognize quite a few of you. So nice to see, and thank you to everyone for coming today. So I'll just do a little bit of an introduction about myself. So I'm a care and transition facilitator on the Inpatient mental health unit. It's the artist formerly known as discharge planner and case manager, and now our new title is care and transition facilitator, but I'm a social worker by background. So that is my official job title. So today, as Laura said, we're going to talk about consent. So informed consent and legal framework for consent. And I think what we had decided that it would probably be best if people could ask their questions towards the end, just to kind of keep the flow going. But please write down any questions if anything comes up that kind of speaks to you. So we thought that this would be an important presentation to do because, and I used to work in community, and so one of my biggest questions was always, well, why are some people forced into treatment? Why are some people not? Why are some people released against medical advice? Why are other people not? And so we thought it might be helpful to kind of outline the rules and the legislation that governs the work that we all do, because it affects all of us working together. So a fundamental principle of healthcare in Ontario is that treatment, whatever that is, shall not be provided to an individual without them providing informed consent. So informed consent means that information must be shared with the individual for there to be informed consent, which includes the nature of treatment, expected benefits of the treatment, material risks and side effects of the treatment, alternative courses of action, and the likely consequences of not having the treatment. So that is what we tell the person. And then what is their informed consent? So to demonstrate that a person has the ability to provide informed consent, the person must have received the same information about a treatment that a reasonable person in the same circumstance would require to make a decision, and the person has received responses to his or her requests for additional information about the treatment. Okay, so that's a sort of very quickly review of what informed consent means. So I'm going to hand over to
Mark.
Dr. Lachmann. Mark.
I always like to shake hands before a presentation because a number of years ago I was at a very, very scary forensic psychiatry talk in the United States, and the gentleman who was giving the talk, he shook the hand of everyone who came in, and it was really good. It generated a whole bunch of discussion. So that's why I did that sort of creepy welcome when I said you're here. So I'm a geriatric psychiatrist. I actually strangely don't work at St. Mike's. I work at Bridgepoint. But I spent a lot of my time doing home visits in the community. so sort of east of the Don Valley, and work with Wood Green, CODA, and some other agencies. So I think that's why I'm here. And I'm hoping that the first little bit is we're gonna talk about the law, and then as we do the case studies and discussions, sort of the meat of the matter, how this is actually lived and experienced. Neither of us are apologists. By that I mean the system really doesn't work in many ways, but we have to know what it is to allow ourselves to work to have some reasonably safe outcomes for the clients who we work with. The other thing that I really want to stress about this, and this is what I also stress when I talk to physicians as well, is that everywhere, every state in the United States, and actually every province in Canada, does this slightly differently. And capacity and how we evaluate capacity are legal constructs. So when it doesn't make sense from a commonsensical point of view, it's because it doesn't make sense from a commonsensical point of view. The way that we work in Ontario is governed by legislation, and we're going to see that in the next few minutes.
And maybe to sort of piggyback on that, I'm originally from Vancouver. I moved here 8 years ago. And when I started working in mental health here, I was like, consent and capacity board? Like, it doesn't exist outside of Ontario. And I was shocked by the fact that we have mini hearings on the inpatient unit all the time. It's a very Ontario specific.
And have people here heard of the Consent and Capacity Board? Put up your hands if you've heard of it. Yeah. So we're already getting off track. Anyway, but the Consent and Capacity Board is actually seen in other jurisdictions, other places in Canada, as actually the gold standard of how to do this. So other places in Canada, North America, think what we do is excellent. So put that in your pipe and smoke it. Okay. So capacity is also related to specific situations where people who we're working with, we feel we just can't, we don't have a grasp that people understand what we're saying to them. And when should we assess capacity? Well, in my world, it's when we're offering a treatment, or when we're making a suggestion about some specific intervention. And I'm hedging my words a little bit because as we talk through the legislation, I'm going to make some specific comments. But essentially, if I'm assessing capacity for someone, it's because I'm saying I think you should do something, or take some medication, or live somewhere. And the person either, I think they don't really understand what I'm saying. And times when you think about capacity are when there has to be a reason. So we don't just evaluate capacity just willy-nilly. There has to actually be a reason as to why we talk to Bob or Sue and we assess their capacity. We have to think, oh, they're not really making sense. And the last line is very important. A person is presumed capable until proven otherwise. The other thing is if I'm uncertain about their capacity, they're still capable in Ontario. The test for capacity comes from the Health Care and Consent Act. So that means that in the Health Care and Consent Act there is language that says a person is capable if they understand the information, and usually the language that we use is, the example is around diabetes because it's relatively simple. Someone understands diabetes, so they can say it's about sugar, the pancreas doesn't work, you have to watch what you eat. They understand it intellectually, that's what understand means. Appreciate means that they get that it relates to them. So, oh, yes, I understand diabetes, and that's got nothing to do with me, that's my neighbor Bob. But actually, no, you, sir, have diabetes, but it's actually how it relates, the information relates to them specifically. And this is called the two-pronged test, the double barrel, the two aspects of capacity in Ontario. Have you guys heard this before? That? Okay. All capacity assessments, however they're done, come back to this statement. They understand, do they appreciate? And if you're ever struggling, they understand, they appreciate. And if you're ever reading long, complicated notes in the back of your mind, is this kind of helping me figure out if they understand or do they appreciate. You don't have to fail both arms. If you understand but you don't appreciate, you still fail the test of capacity. And to be clear, this is a legal definition. So it's not a clinical decision. This is how they figure it out in the law. The legislation that governs capacity assessments and incapacity, these are them. The first four are provincial. The last one is federal. The one that most of us live and breathe all the time is the Healthcare and Consent Act. The second, really, where all this comes from is the Mental Health Act. So the Mental Health Act essentially built the whole framework for consent and capacity and the appeals process. The reason there is a consent and capacity board is because in the Mental Health Act it says there is a consent and capacity board, and that the process of appeal, if someone is found incapable, is laid out in the Mental Health Act. Why I'm going on about that is the Mental Health Act works pretty well in the hospital. So on an inpatient psychiatric unit, it works pretty well, and it's set up to do that. So the whole consent and capacity board mechanism was set up to live on an inpatient psychiatry ward. So there are processes in place. If someone is found to be incapable of taking their psychiatric medication or their medication for diabetes, the physician says, I think you're incapable because of X, Y, and Z. That person then is set up to get rights advice from a rights advisor who is actually a person who's paid. They exist, and they come in their forms, and they go and see the person and say, you know, this is what's happened. What do you want to do? Do you accept the finding of incapacity? Yes. Oh my God, those doctors were idiots. I don't think that's true. If they don't accept that, then they're assigned a lawyer, and there's a hearing before the Consent and Capacity Board, and then the physician, the psychiatrist, makes their case, and the person actually doesn't have to say anything because we have to prove incapacity, but they may say things, or their lawyer may say things that poke holes in what the person is, what the psychiatrist is saying. Then there's the decision by the Consent and Capacity Board, either they're capable or not, and that's done. But interestingly, that consent stuff around treatment decisions was actually piggybacked on detention decisions. So the original reason for that Consent and Capacity Board was actually, yes, it was around consent, but mainly it was, we're forcing you to stay in hospital. You don't want to stay in hospital. We're going to have a hearing. Okay, we agree with the doctors. You need to stay in the hospital. But actually, we don't agree with the doctors, and then off you go. I'm saying that because part of the clunkiness of all of the consent and capacity assessment stuff is that it wasn't actually built for the outpatient setting, for the real world decision makings that people live in. It's kind of all been piggybacked on this legal infrastructure which was built specifically around the Mental Health Act and the detention of psychiatric patients in hospital. Does anyone have any questions about just the legal act stuff before we move on? I don't know if you have anything to add.
The lawyer, in accessing a lawyer?
Yes, yeah.
Is it a subgroup of lawyers that's not really accessible, or do they have to?
So usually they're legal aid lawyers, and I don't set that up. What happens is there's the Office Privacy Accountability, I almost forget, PPAO. Patient Advocacy Office.
Patient Psychiatric Advocacy Office.
Yeah, so they're the group, they're actually a physical office with people in it, and they're the folks that call, the hospital calls, the person needs rights advice, they come, and they help arrange, as far as I'm concerned, a legal aid lawyer who will come and represent that person.
And I mean, maybe just to say, because I think it will come up again and it's important, is that, you know, this process is a lot of work. I mean, it's a lot of work for the doctor because as well as seeing their patients, they now have to prepare for a hearing, which is going to happen on the unit. And another really key important part is that while that hearing is waiting to happen, and it can take, it's common for it to take 7 to 10 days for the hearing to happen. That person can legally not be given medication. So that 7 to 10 days that this person is in an acute care bed without medications, not getting better, often getting worse, and it's sort of it's a stall. So
if a person is found incapable, and to be really, really, really specific is important. So if individuals, as they go through this consent and capacity award process or are being found capable or incapable, are not globally incapable. People are being found capable or incapable just around a very specific treatment decision. So it's actually common for psychiatric patients on an inpatient psychiatric unit for me to say, oh, I'm assessing Bob. I don't think he understands the information around his schizophrenia, and I'm finding him incapable of making a treatment decision around his schizophrenia medications. But actually, I do think he's pretty capable of making decisions around his blood pressure or hypertension medications. So a person would be found incapable just of that. It's not even about medications in general. It's just about, it can be about the specific kind of medicine. This is very, very important because often the language is porous, and it's a common misconception that if someone is found incapable, it's not just about that specific decision. The other thing is that people's capacity can change, which again can make this more confusing.
I think there's a slide on that too.
Perfect. We'll get through this and then we'll come back to the question in a moment. So if someone is actually found incapable, they either don't want to go through a review process, or their finding of incapacity is sustained by the Consent and Capacity Board, who makes decisions? Because somebody always has to make a decision. And that, again, is laid out in law. So there actually is a hierarchy of substitute decision makers. And in the Health Care and Consent Act, it's actually listed. So I can't make it up. I can't say that this person is able to do this for you. And this is just a list. So the first that trumps everybody is a court-appointed guardian. So some judge somewhere said, you are going to make decisions for that person. The second is an attorney for personal care. This is actually really, really helpful. And this is one of the reasons why we spend a lot of time trying to have people have powers of attorney for both personal care and finances set up. And the nice thing about that is never pay a lawyer money to do this for you. You can just print off the forms from the Ministry of the Attorney General, their forms for personal, and you just use those forms, and they're free.
Maybe I can jump in there because we have this happen a lot in inpatient psychiatry. So this would be the second person, would be the second on the list. You have to have appointed that power of attorney before you've become incapable. So we will have people who are, they'll be held on a psychiatric unit, they've been deemed incapable, a substitute decision maker is going to be appointed, and the person will say, well, I want so-and-so to be my power of attorney. Unfortunately, it's too late at that point. The window has closed. It needs to be from before you were deemed incapable.
And interestingly, just because you're married to someone, your finances, it doesn't mean they get to manage your finances. So my partner and I, weirdly, we both have powers of attorney for finances set up for each other because, I don't know, I'm paranoid. And but it's just, so there's a little file that says if something horrible happens, please take this to the bank and don't take all my money. And then there are these other individuals that are there. And sometimes it gets actually quite confusing as to who is a relative, who is what, where, and when. And that at no point anywhere in Ontario is someone not there to help make a decision. So the decision maker of last resort, if someone is incapable, is the public guardian and trustee. And what that means practically is if I'm working either in the community or in the hospital and I can't find anyone, and someone needs to have a decision made about some sort of treatment, and it's not an emergency because it's not quite that urgent, but it is kind of urgent, we can always call the public guardian trustee and explain the situation and say, this is what's going on. What do you think? Does this make sense or not? And the reason that's there is just to actually protect people against, well, us really, physicians. And the idea is that there should be some way of having oversight of that.
Interestingly, at St. Mike's, and I would guess at Bridgepoint it's probably similar, I would say, don't quote me on this, but statistically probably half of our patients' decisions are made by the public guardian and trustee. So depending on your population, it will differ. So at St. Mike's, we have a lot of patients with psychotic disorders, we have a lot of patients that are homeless, and we have a lot of patients who are sadly estranged from family or do not have a person that would fall under this list. So often the public guardian and trustee is involved.
And then we alluded to this earlier, that if someone is assessed by someone proposing a treatment and they disagree with my finding of capacity, there actually is an appeals process. It works much better in the hospital setting. It's very hard to set up in the outpatient setting, but it can be done. We've done consent and capacity board hearings in basements of places, and I would never expect anyone here to have to set this up. I think that would be a team of you and the people you work with would do this together. And if you have any questions about the consent and capacity board, call them. They're actually quite nice people. When you're not asking them for anything, they're very friendly. And they can tell you about the process. Yeah. And a lot of, Nicole, you may disagree, but a lot of what we have just presented, you now know more about consent and capacity than most nurses and physicians that work in private practice in the community.
Oh, yeah.
And again, the most common mistake is that it's just like the way it used to be when I practiced or I learned my job in BC or Nova Scotia or Colorado. And it's not. It's a very specific, it's not commonsensical, it's related to legislation. Just before I move on, you had a question.
Well, I was going to ask if it covers dentistry as well. No.
Well, no, it does. Yeah. So it would be a treatment. So the dentist would have to explain, I'm going to take out your molar. Do you understand? And then they would say, no, and then they would run away. And that would be incapable. One thing, though, that we'll get into, I think, in the discussion and the questions is this is a legal framework. There are lots of real-world limitations to many of these things. So I'm sure we'll get into that in the discussion. Please, Nicole, you're...
Yeah. So financial capacity. Should we swap? So this is a big topic, particularly because so many of the people we work with are on very marginal incomes to begin with. So financial capacity are basically undertaken in order to provide a formal, independent assessment of a person's capacity to make financial decisions. So, you know, an assessor will determine the person's understanding of the finances, if they can accurately identify their finances, if they can do basic math, if they can interpret their information, if they can basically provide the kind of who, what, when, and why of their money, and like I said before, basic arithmetic. So, you know, one of the most common ways, and we'll talk about how these get done, but one of the most common financial capacity assessment requests we get when people are on inpatient units is this person is on ODSP, so they're already getting minimal amounts of money. They are, you know, spending all their money quickly, and then they have no money for food or accommodation or anything like that by the end of the month. And then so that could trigger a financial capacity assessment. You know, part of the reasons, and I struggled whether to put poor in this, making poor decisions, but it's important because a lot of times, especially as addictions, you know, when addictions overlaps with mental health issues and people end up admitted on a psychiatric unit, we are asked to assess people's financial capacity based on that. And it's unfortunately, but it is what it is. People have the right to make decisions that we might consider poor or not. But spending your money on substances is not generally considered a reason for financial incapacity. Or being in an abusive relationship and giving all of your money to a person and then being out of money is not a grounds for financial incapacity. There's also examples, though, that if a person's giving all their money away to another person because they have severe cognitive impairments, then that may change the decision of financial incapacity. So who completes financial capacity assessments? Basically, there's two ways, and maybe I'll talk about the attending physician first, because that's sort of what I'm speaking about. So Mark's kind of talked about it a little bit too. So under the Mental Health Act, legally, every physician in an inpatient psychiatric unit, and sometimes they call it a Schedule I facility, that means an involuntary, a place where you can keep people involuntarily. Every physician needs to at least formally or informally assess a person's financial capacity. So as we said before slides ago, that capacity is assumed. So we come into it assuming everyone is financially capable. But in a Schedule I facility / inpatient psychiatric unit, the doctors have the ability and actually have to assess a person's financial capacity. So according to the Mental Health Act, all patients in an inpatient facility must be examined by their attending physician regarding their abilities to manage their finances. So in my experience, that's where the majority of them happen. Unfortunately, it doesn't matter if they're in the ER for psychiatric reasons, that doesn't count. It has to be an inpatient psychiatric unit. And then a capacity assessor. So this is someone who has been trained and deemed qualified to determine if an individual is financially capable, and this falls under the Substitute Decisions Act. So I believe it's doctors, social workers, nurses, occupational therapists, and pharmacists, I believe, all have the official training, the official capacity to become a capacity assessor. There's a process, and it's all governed through the Attorney General. You know, I'm a registered social worker, but I couldn't just show up and call myself a capacity assessor. There's a process of qualifying, registering, being certified, and then you can do capacity assessments. So this is just a summary. I mean, do you think it's helpful if we go through this? I mean, I think we've kind of talked about this, but basically this is the capacity to make psychiatric decisions and financial decisions. So we'll talk about psychiatric decisions first. So what the assessment covers is the ability to provide informed consent, requires the ability to understand information and appreciate the consequences of decisions. Who can administer the assessment is the treating psychiatrist of the patient. And as Mark said, it's often much easier in an inpatient facility to do that. I mean, capacity for psychiatric decisions technically is 6 months long. So if a person is deemed incapable and then discharged into the community, unless the capacity has been reversed, they still, by the letter of the law, are incapable to make psychiatric decisions. But you can't really enforce that unless they're on a community treatment order, which is a whole different topic. So process for obtaining the assessment, again, the treating psychiatrist assesses the patient and makes the decision, and that's what Mark talked about. And then the implications of the assessment is whether or not the hierarchy of decision makers must be used to engage the individual in decisions. And so capacity to make financial decisions, again, very similar. We talked about it's the purpose of it and what the assessment covers is their ability to manage their funds, capacity assessor, or the attending doctor in an inpatient psychiatric unit. And the process for obtaining the assessment is you contact the capacity assessor or the attending doctor in the unit. And so you go on it's actually, if you Google the public guardian and trustee, they have a list, a capacity assessors list, and that has got a lot of different names of people who will do financial capacity assessments. I think there's another, so they're expensive. So maybe I'll talk about that just for a second. I mean, they're about $750 to $1,000. And it's much more complicated because the person requesting the assessment usually has to pay, which unfortunately, if you're working for a community services agency, most don't have that kind of money to do it. The second part is that the person actually has to consent to it. So, I mean, I know a lot of our patients, if they're out in the community and you're saying, oh, we're going to financially assess your financial capacity, they're not going to participate, let alone maybe show up. So it's a very difficult situation, and I think it's why often people end up using the doctor when people are admitted to psychiatry. Did you have something to say about this?
Yeah, no, I was just going to say that in the community setting, it's very difficult because it's voluntary. The person has to agree to do it. The second is it's expensive, and the individuals who do the financial capacity assessing, it's their business. That's sort of what they do. And in my experience, there are some people who are cheaper. There are also sometimes agencies have some money tucked away that they will help pay for some assessments that they think they need to do. And the PG&T also sometimes will facilitate. There's some money that you can apply for that will assist. Sorry, Sarah. Yeah. Yeah. That's right. And that pot it's not an unlimited amount of money. They usually start at the beginning of the year with some money, and by a period of time they run out. We'll talk about this at the end, but it is one of the things that it's an opportunity if you have organizations, it's a pressure point, because some people actually will accept going through a capacity assessment, but they don't have the money, obviously, to pay for a capacity assessment, but it can make a real difference in preserving housing. And it's something that if there is philanthropy or people are giving money to an organization, it can be helpful to have it go, ironically, into a fund that would help people become financially incapable, because sometimes that can preserve housing. It can make sure that bills are paid and other sorts of things. But I'm sure we'll get into that.
Yeah, and we'll talk about it more with the case study too, but I think, the best way that you can advocate for the need to have a financial capacity assessment done is any evidence. So, documentation stating that this person has been cut off ODSP because they haven't gone in for their annual review, or they haven't submitted the documentation that's needed, or they haven't paid their rent and they don't really have a good explanation as to it. They've got bills at Money Mart, things like that, any documentation like that, because we'll talk about this probably with the case studies, but if a financial incapacity assessment goes to the Consent and Capacity Board, I think it's something like 5 out of 10 of them are actually overturned in favor of the patient, which is much more than psychiatric treatment decisions. Most decisions by the board for psychiatric treatment decisions are upheld in favor of the hospital. And it's a bit opposite with finances. So, case study. So this was actually created by, I believe it was Homes First? Yeah. I changed some of the wording around, but and gave her a name, but this is a fake, all these people's names are not real. So this is a financial capacity case study. So Betty is an 81-year-old female who's lived in supportive housing for the last 4 years, following homelessness for many years previous. She has suspected mental health issues, but does not have any diagnoses. She will only minimally engage with certain staff, and her income is a combination of CPP, GIS, and OAS. She pays her rent in cash and will only do so with repeated prompting. So in early 2019, Betty fell into arrears with her housing as she became more reluctant to pay her rent and offered confusing explanations as to why, such as the train hasn't come or it's in a vault in Hamilton. Betty eventually stopped paying her rent altogether. So Betty and housing staff called the CRA together. She could not pass the identifying questions, but it was determined she had not filed her taxes for several years and was not receiving her GIS, and she had exhausted her savings to pay the rent. Betty does not seem to understand the situation, what she needs to do to rectify the situation, or the fact that she could be evicted for non-payment of rent. So this is a very common scenario at St. Mike's. I wouldn't say this is irregular at all. So maybe I'll turn it over to the group. Do people have a sense, based on some of the information we've given, of what the next steps could be or what your options could be in this situation?
I mean, I wrote the scenario, and one of the reasons I wrote it is we could have all. Because I've some background, shepherded several clients. I haven't even attempted.
Yeah. And it's interesting. I mean, there are so many people like this, and I would anticipate as the baby boomers age, there's going to be a lot more. But there's a lot of people who are kind of in the middle, right? They're not getting picked up by the police because they're just sort of keeping themselves to themselves, and they're declining quietly. And those are not the people that are getting brought in against their will, because they're quiet and they're also supported. So it's kind of a perfect storm of them not getting help. So what we had thought was, okay, you've got sort of your two options here are that if Betty is admitted to an inpatient mental health unit, request that the inpatient most responsible physician complete a formal financial assessment. Now, you've talked about the challenges getting her there. What I would recommend if I was in the community in this case, what I would recommend is doing a Form 2 again. And if that's not the route, then sometimes you have to be creative. But you can make a case that she is very much in danger, and that may not be grounds to get her on a Form 1, but it would be, I think, grounds for a Form 2. She's, an N4, and N5's been issued. She's going to be evicted. She's got these cognitive impairments. Some patients too, like I think at St. Mike's we often have a lot of social admits. We do, where the person doesn't have an acute psychiatric issue per se, but they have what everyone suspects is a cognitive impairment that's getting worse, and we know how it's going to play out. So that's, and again, like I've put all my contact details on the first slide, and I'm more than happy to take any kind of calls with confidentiality. Obviously, you can call me though and ask, what in this situation, what would you recommend? And sometimes we can brainstorm, like we do this a lot with different community agencies, because sometimes it's, you got to be a bit crafty, right? And
have been, so,
yeah.
I mean, just with the JP, they've asked, and I've had a recent.
So I'm going to ramble on for a little bit,
Okay.
all right? And not to provide any solutions really, but just to provide some context and muddy the waters a little bit. So the first thing is, actually it's recognized in Ontario that aging seniors, the law doesn't match up to the reality. So a number of years ago, the Ontario Law Review Commission was reviewing how to change the laws across the province to deal with making everything make a little bit more sense as we're aging with dementia. And they made a whole bunch of recommendations, and that's just sitting on some file somewhere in Queen's Park. So at some point, they'll get to it. But it actually, if you read through them, I don't actually recommend you read through them because they're really boring. But they don't really get into the weeds of this. So I'm going to just give you some other options, and you can think about them and take them with a grain of salt, okay? One thing that we haven't talked about is the bank. So one thing we have not talked about is the bank, so banks. So banks in Canada are regulated under federal legislation. And there's actually like a federal banking act. And sometimes what you can do, so the bank, independently of anything that goes on in provincial legislation, they do not want their customers to be defrauded or to lose all their money. And sometimes what you can do as a person working in the community is gather the evidence. So you actually can write down, you can have a little, this person is doing this, this, and this, and this, and this, and this, and you can actually take it to the bank, literally, and say, Sally is doing this, this, and this, we're really concerned about her. Is there anything that you can do?
Bank.
Her bank.
If we know that.
If you know that, and you may not. She may keep all her money in cash underneath the litter box or something. But sometimes that's helpful because the bank itself, they under law, there's some stuff written in there that they have to be a bit careful how they manage frail and vulnerable people. Which brings to the point of diagnosis. So if they're able to see somebody like a physician and says they have a dementia, that changes things. The other thing that you can say, and this is really muddying things, but you can say, gee, I think she has a delirium.
Yeah, I know, the UTI.
No, I mean, but it's very, very, very important because there are two big things that go wrong with older people. Dementia, a delirium. So dementia is the one that everyone thinks about, which is a gradual decline in cognitive function over years, and there are many different kinds of dementia, but that's the one that everyone talks about. The other thing that's much more common actually in the frail elderly is a delirium, which is an acute confusional state caused by an underlying medical problem. It can be caused by a heart attack, pneumonia, urinary tract infection, and it also happens in people who happen to have a dementia. And the thing about delirium is it's reversible. in that when you treat the underlying cause, you can actually have them come out of that confusion. It's actually not 100% true. There's about 5 to 10% of people who don't come out of it, but whatever.
Never mind.
But the point is that it's very muddied. The other thing is, you may have noticed that this sort of individual is toxic to a hospital. It's almost like they get near a hospital and they're bounced away, because the hospitals just simply often don't want to admit the frail elder that will never leave until they're waiting for long-term care. But what you can do, and this gets to the relationship that you may or may not have with your inpatient psychiatric unit or your team, is, and it works actually much better in a small community hospital than a large downtown institution, although people are warm and friendly, but everyone just knows everyone, is that you make an arrangement ahead of time, you call, there's some integration of how that team works, and you sort of essentially say to someone, this is what's going on, I know this is what's happening, but really we need to get a financial capacity plan. And then they're admitted, and they're just for that period of a financial incapacity, and then off they go. That can be helpful. The other thing, and this may be totally impractical, is the power of attorney for finances and personal care. The threshold is much lower to assign someone who you know and trust to get your finances done. So it's much harder to pay your taxes and your mortgage. It's terribly complicated. But it's easy to say, I trust Nicole, and she's going to look after my money. You have to be a bit careful about that, because obviously, you can't have yourselves or nurses or PSWs do that.
Yeah.
But if there is some long-lost relative, it can be helpful. The other is voluntary trustee stuff, which maybe we can talk about at the end, but that can be a bit of a wiggle room. This is really very common, and there is no really great solution to it other than trying to be as creative. One thing that I'm always struck by is in the community, it's like we're watching a train hit a wall, and you're just watching the train hit the wall, and she won't get help until she breaks her hip. And unfortunately, that's how it can be set up. So for me, that becomes about a relationship, and I think that's the challenge that the hospitals have to have, and also the community. I worked in small communities for a long time before I came to Toronto, and I knew everyone. I knew all the nurses, everyone knew me, and we would have a relationship.
As do we.
Yeah, and that's a conversation that I think to have with whoever runs the inpatient unit, and you just can sit down and you beg, and you see what happens.
We've been down.
Yeah.
I mean, the issue is it's a larger system issue.
Of course it is,
Those
yeah.
files that are sitting up there,
Yeah.
like us need to come out, because we got to connect this to the homeless.
Totally
I agree.
And I think it's hard, right? Because I think we all have thoughts on how the system needs to change and tweak, and I think that's really important, and there's a part for that. But I think also too, in the interim, we have to work in the system, and so it's helpful that we all kind of can get on the same page, and at least we understand how to navigate.
Oh, absolutely. I
The
agree, but I think that it's also great that hospital and community agencies coming together.
I think there are lots of options. I think advice from the Advocacy Center for the Elderly can be helpful. But also one thing that I found helpful, although it takes forever, are the spider tables through the City of Toronto. Do you know what those are? Have you heard of those? Or? Yeah. And sometimes they're helpful only because there are people around that table who I never even met, like the city tax people, the public health people, the fire department. And sometimes they can say strange things like, oh, all the fire hazard things are covered with newspaper. And that actually means more than me just saying it. It means the fire department comes and they go into the house and they do things. And sometimes that can be helpful. I've actually stopped going to those meetings because I was the only geriatric psychiatrist and they wanted me to go see everyone in the city. So I can't do it. But it's creative because it brings all the different people together who have contact with frail elderly. And I hope it keeps going.
But yeah, you're right. In Betty's case, like, it's kind of a rock and a hard place.
I think that's why it's important that to where it needs to be.
Join our discharge committee, Jamie. Are you on the? Okay, good. So this gentleman was first. Sorry.
So what can the banks do? You had mentioned the banks.
Well, they can do anything. I mean,
Aside
you.
from
Yeah, so banks, under the federal banking, they're very powerful. They can actually shut down accounts. They can, so they have so the language, in healthcare we talk a lot about fiduciary responsibility, which means I have a responsibility to my patient, not just because he's my patient, but I am obligated to act in your best interest. That language does not come from healthcare. It comes from the law, and it comes from the banks. The bank actually has a responsibility when someone goes in. They kind of have to figure, there's something in legislation that says they have to know the person who it is, and they have to have some sort of due diligence that this kind of makes sense. And that's a really basic thing. And so by that basic, I mean it's not terribly sophisticated. But if you have concerns as a community worker about, you know, Sally is getting all her money, she's not paying, and she doesn't really understand what's going on, with evidence, and this is perhaps, if there's one point I'd like everyone to take away, regardless of the legal framework, reality eventually wins out. So something will happen to Betty and she's going to need care. Something will happen about the finances and she'll be evicted or the home will fall. And writing things down that, you know, for the 10th month in a row, she hasn't paid her rent, there's no food in the fridge, the money, no one knows where the money, and going to, don't meet with the bank teller. Another person you want to have a relationship with is your local bank. Call the bank manager and say, I'm Sam from CODA. I have concerns about the finances around this person, and I'd like to share that information with you. One thing that people often get wrong about confidentiality is that as a bank manager, or I'm not a bank manager, but as a physician, I can listen to anyone telling me anything. And if you, in the course of whatever you're doing, you're watching the wheels fall off the bus, you can watch the wheels fall off the bus and you can talk to the bank manager or you can talk to me about what's going on with Sally. And that's just another tool in your toolbox. Again, it's not a panacea, but it can be some other avenue. The problem is what often happens is then everything stops. So then there's no money for anyone to do anything, but it can motivate somebody like Betty to engage with a financial community capacity assessor.
It would be something like restricting access
Yes.
to the account. It wouldn't be something like an allowance.
No.
No, because they can't determine that.
You have access or you don't have access.
Yeah, it'd be a very basic kind of minimalistic safety kind of thing, and it'll depend very much on the bank manager. But there is legislation. You can go look it up, Federal Banking Act, and there is stuff there about vulnerable people.
So we have 2 more slides after this. I know there was a question over here. Sorry, who's it?
Yeah, no, I was just going to offer a suggestion, a really helpful thing for myself in those situations.
Yeah, and I would say the same. Our social workers are very, our social workers in the Emerge, I know, take a lot of calls from people in the community. And I think Mary's going to pass out at some point. I don't know if it's been distributed yet. But we are in the process of making a contact list for contacts at the hospital. And I'm on there. And the social workers are on 7 days a week in the emergency department, and they're always accessible by phone. So has that gone out yet or no?
Not yet, but I'm wondering actually about the gem nurse.
And it sounds, yeah, I think that's a great idea. It's a great suggestion. And another suggestion, sometimes none of us want to actually have a person be at threat of eviction, right? That goes against what we do. But having a person be issued an N4 or an N5 can really sort of ramp up the need or the consideration of an admission. So with Betty, for instance, saying this person's at risk of eviction if they don't pay the rent, well, has an N4 been issued? No. If you actually get an N4 issued, then you're actually saying to...
Yeah, we file it.
Okay, so...
It's not just served in N4, but she's been filed, but she has no capability. So our choices right now are eviction or
Right.
let her stay there forever without paying rent.
Yeah. So I guess I mean that giving that information to the admitting team, like if you're looking to admit.
We could get her admitted.
Yeah.
This is enough.
Right.
Yeah.
Right. But if you're if you're advocating for someone to be admitted to hospital, saying this person's 81, has very suspected dementia,
Just
and
get
is
her to the hospital.
getting an N4. Right.
We can't get her to the hospital.
911. She has a delirium. I mean,
The other thing, just to make you feel better, is that, so I'm a subspecialist geriatric psychiatrist. I work in the community sometimes. Sometimes I even myself complete a Form 1, and off the person goes, and then 2 hours later they're back home. They're discharged. So there can be disconnect.
should we cruise to the next slide? I'm just wondering, because I'm kind of mindful of the time. So this is the case study 2, capacity to consent to psychiatric treatment while in an inpatient psychiatric unit. So this is John. So John is basically, you know, the patient I work with the most often. He's an amalgamation of lots of different people. So our bed is a 33-bed unit. We have 2 social workers, myself and my work wife, who are responsible for all the discharge planning and coordination of 17 patients each, or 16, depending on how it is split. So John has a diagnosis of schizophrenia, was brought to the emergency department by his worker for bizarre behavior, tampering with the program site alarms, barricading doors. He's been hospitalized before for a similar presentation. He's shown improvement of his symptoms with medication during previous hospitalizations. So that part is important, because I think you spoke to it before about Box B criteria. And the Mental Health Act is very complicated, but Box B criteria means that a person is at risk of deterioration if they don't get treatment. But the key bit of that is that they have to have shown documented improvement in the past on medication before. So in this case, John has. We know he's been in hospital before. We have records saying that he's improved on Invega, what have you. So he's transferred to inpatient mental health. During his meeting with the psychiatrist, so this is the psychiatrist trying to assess his capacity to make psychiatric decisions. During his meeting with the psychiatrist, he demonstrates he's able to understand the information about schizophrenia and that it can affect some people. However, he does not believe that he has this illness in spite of a 2-year history of symptoms consistent with schizophrenia, hospitalizations, and treatment. So he is found incapable of making psychiatric treatment decisions. And it's a bit like Mark talked about with the diabetes. So the person knows that there's a disease called diabetes and his neighbor has it, but when it comes to his own issues, he doesn't believe that he has it. So we said, why is this? And I guess I would turn that back over to you guys. Does this make sense of why he is determined to be incapable? Do people have questions on that? Thoughts? Outrage? Anything? This is kind of an open and closed case. This is pretty obvious to me why he's found incapable. I mean, now John might not agree, and a lot of times people don't agree. But in this case, I think by the letter of the law, this is a pretty typical case.
He's failed the appreciate part.
Exactly. Yeah, he has failed to appreciate. This is an explanation of why John was found incapable. So he would be placed under a Form 33. The doctor proposing treatment will look to their substitute decision maker, and that was that previous list that listed them all out. And then, as I said before, he can't get any treatment until if he legally can test this finding to the CCB. So until the hearing is held and a decision is made, he cannot legally be given any medication. And then once a decision is made, then we could move forward to treatment. So sometimes you're looking at people, literally this happens all the time, particularly on a long weekend when the consent and capacity board is not operating, where people will be in hospital for 13 days without any treatment. This is Bill. So Bill's brought to hospital by police after demonstrating aggressive behaviors towards other people, so accusing them of being spies. He's been using crystal meth prior to the incident. He was placed on a Form 1 by emergency room doctors due to being a danger to others. So he's transferred to inpatient psychiatry. Following 2 days of sleeping and some PRN, which stands for as needed medications for agitation, he is significantly more organized. And when we say organized, we mean able to answer questions, go to the bathroom, walk around, things like that. He meets with a psychiatrist and states he is aware that his meth use caused him to become aggressive. At this time, he is calm, controlled, and denying all psychiatric symptoms. His diagnosis at this time is substance-induced psychosis, and Bill is ultimately found capable to make psychiatric treatment decisions. So what do people think? Do people have thoughts? Does it make sense? Do you agree? Do you disagree? If everyone agrees, I'm also happy. I don't. I'm kidding. Yeah, I mean, I think that this is a very, very common scenario. So he has been found capable of providing informed consent to psychiatric treatment. He's told he can stay in hospital as a voluntary patient and begin an antidepressant for his chronic low mood. He has stated to the doctor that he does not want to take any psychiatric medications at this time and would like to leave hospital. So because he has been assessed and has been deemed a capable patient to make psychiatric decisions, he does not at this time meet criteria of being an imminent risk to himself or others. So that would be what we call box A criteria. He decides to leave the hospital and is therefore discharged by the doctor against medical advice. So I think this is a very common scenario, and often I think a common scenario, particularly when people are using substances, but it's not unique to substances, and it's often happens in the emergency department, although it happens on inpatient psychiatry too. Does anyone have any thoughts or comments about this, or questions of why this happens, or?
I mean, I think these are really good examples because they actually illustrate how all this doesn't actually apply to Betty or the aging patient who is a gradual progressive decline. And it's an example of how that legislation is set up to deal with the psychiatric patient. And if, I mean, I'm a geriatric psychiatrist, but sometimes another way is really thinking about the medical decline. If there are things in somebody's medical condition that is coincident with the cognitive decline, sometimes that's a way of getting individuals some more care. But there's a real variation across the province of Ontario about how the patient with dementia is handled in emergency rooms and hospitals. Some places these individuals are admitted to the medical floor, and in other places they're admitted to psychiatry. Most of the units in Toronto, they're adamantly not admitting any of these individuals to an acute psychiatric unit because they feel, to your point, that it's felt they don't have an illness which is psychiatric that can be reversed or treated. At the same time, most of the time when I work in an acute care hospital, I see many of these individuals on a medical unit. It doesn't really matter sort of where they go as long as they get some support.
Well, and to kind of build on that, every unit, I'm convinced, like every general internal medicine unit, every psychiatric unit in the city has at least 3, often more patients who have a cognitive impairment that can't be discharged. So on our unit, we have 3, where they have no reason for being in the hospital other than their cognitive impairment is such that they cannot safely be discharged. And so, you know, it's a real balance because we obviously are concerned about the Bettys of the world. And then on the flip side, we have to think about, you know, the resources of that. We have 33 beds to treat, you know, in the busiest kind of psychiatric hospital in the city, I would say, to treat acutely psychiatric people. And if those beds are full of people who ultimately can't be discharged for years, where are those patients going to go for their treatment? And so it's a huge systems problem. Yeah, happy days. Okay, so that brings us to the Q&A.
Does that consent still valid?
Oh.
Can you repeat the question just so I catch it on the mic?
So the question was someone who has dementia, lots of short-term memory impairment. They consented to having a financial capacity a number of days ago, but by the time of the assessment, they've forgotten that they've consented to the capacity assessment.
That's right.
I think if I were the financial capacity assessor, I would want to have that conversation with the person because it really is in real time that they're doing the assessment.
So they have to consent in that conversation.
Yeah. The other thing, though, I want to make a general point about dementia because it was very educational to me. Years ago, I worked in a community of about 2,500 people, and we were caring for a gentleman who had a true Wernicke-Korsakoff's dementia. He had no short-term memory. And he was fine. And he was living in the community, and the reason he would go see John every day at 2 o'clock for a cup of tea, and he'd been doing that for 30 years. And it caused great consternation amongst the professional staff. You know, how can this person be living in the community? And he continued to live in the community because, again, nothing had changed. And if I were to take that person and drop them off in the city of Toronto or another city, he would die. He would literally be hit by a bus. And there are individuals, certainly that I have in my practice, that score terribly on cognitive testing, and they live in a tower building, and they actually are doing okay. And I bring that up because a lot of how people do in the community is not simply a function of their diagnosis or whatever physical or cognitive is going on. It's also a function of the environment, and it is not consistent. You can't necessarily say that what's working well for Bob in this part of the city or in this environment where he's lived in, even though they physically are described and have the same illness, it may be different. And I say that because that kind of subtlety doesn't really fill out in the legislation at all. And I think it's actually unfortunately just changed. But in the previous, so in the DSM, before the current DSM, we were able to make a diagnosis of dementia without doing formal cognitive testing. All what we needed to do was sort of do occupational health assessments, instrumental activities of daily living. Now, you still can do that, but they've added in, we'd like you to do some cognitive testing. And I think often the most valuable information that you guys can collect is actually just describing in a contemporaneous way. So in real time, this is what each of these individuals is able to do. This is what happened when they got hit by a car when they're crossing the street, and you just keep writing it down, and then you bring it with you as they have encounters with the bank or a clinician, and it's incredibly powerful information. There's a really challenging case that we're working on in East Toronto, and they've had endless numbers of firemen, police, all the different people in uniforms have gone repeatedly. And that information just has not been collated in one particular coherent narrative that is heard by the LIN or the CCAC or but having things written down is something which only you can do because you're working most directly with the client, and having it written down and bringing it in, it's almost like you're assaulting the physician with, this is what's happening. You have to see. Video often helps. I have family members that bring video of their grandfather walking across the street in traffic. Extremely helpful. Please don't let your grandfather walk across the street in traffic. But it really makes a big difference because the tendency of the people working in the emergency room or in the clinic is to discount actually the risk. And if you're able to provide that, it can be very, very helpful. Sorry, I'm rambling.
So the question is, what do you do if you think that the substitute decision maker is not acting in the best interest of the client? Interestingly, we've had this case. Well, I mean, you're a doctor, so you actually take away their. So go for it.
The first thing is to really understand what's going on, and that means just what I said before: writing things down, and because you have to actually build a case. And it's really problematic because often firstly, in many of the patients who I see don't have any family at all. So if there is a family, it's just remarkable. And if there is someone who's a substitute decision maker, chances are, even if they're making terrible decisions, it's probably a strong emotional relationship that is complicated and problematic. The reason I'm going on about that is you and the team that you're working with have to make a decision about the next step. Because the next step is you actually formally approach to have that person be removed as a substitute decision maker. And that just involves a lot of information.
Who do you approach?
It kind of depends. I tend to talk with the public guardian trustee, but then there's a process that you need to go through to remove that person.
And maybe I guess if I'm understanding the question correctly too, it wouldn't happen in the community, right? Because
it does.
but not for community workers, like for a doctor. But sure. Like it would have to be the treating physician would have to remove.
Yeah.
Right.
So we wouldn't expect that would be something that we should all be working in an interdisciplinary team all the time. We should be supporting you and as we go through that process. It is hard and complicated. It actually is really, really important to do. And sometimes in the world that I live in, often it comes around to end-of-life care decisions that are very challenging and difficult for people. There's a process. The process is laid out. Where things fall down is, again, not having the corroborating evidence about what that would be. The other thing that, to your point about the public guardian and trustee and their investigations branch, so the public guardian and trustee has two kind of branches. Maybe they have more, but they're secret and they don't tell us. But the one that everyone talks about is just making decisions. And then they have their little SWAT team, which is the investigations branch. And the investigations branch, in paper, it looks really cool. They have a ton of power. So anybody can call, essentially 1-800 number, something terrible is happening to a person who's vulnerable. And you call them and you describe the situation. And unless they tend rarely to get involved unless there's substantive amounts of money that's involved. But if you can convince them to be involved, and sometimes, again, it's because their assets or the person is about to be evicted, or there's suspicion of criminal activity going on, then they have power to freeze accounts and do an investigation. Part of the challenge if we think something is not going quite right is not, I don't, but you don't, no clinician has the power to actually investigate. People don't have the ability to access and look at people's accounts. Sometimes the police can be helpful. So you may have in your area the community officers, community relations officers, and sometimes they can be extremely helpful if you sit and explain if there's a worry about particularly financial impropriety. The other people that can be helpful again are the banks. And again, having a relationship, if you know the bank manager, and just saying these are the things, it can be really useful.
There's a few people in here, I think, actually, that Mary at this point, but we have so we're on a committee with community members where it's about discharges, trying to streamline and come up with ways that we can kind of make the most successful discharges from hospital to community. And one of the questions that often comes up that we talk about is kind of, if you talk, like we're looking at the patient with the crystal meth use or with any sort of aggressive behavior, is that, you know, well, this person's different when they're in the shelter than they are in the ER. So they get called, they get brought to the ER, the doctor sees them, the doctor makes an assessment that they're not at acute danger to themselves or others. And often the community members I work with will say, yeah, but then it changes like 15 minutes later. And then what do we do? Then we're back again. And the unfortunate thing, like, and it's not ideal, but like a lot of things, and maybe Mark, you have thoughts on this too, the doctor can only assess what is happening at that moment when it comes to, I would say, box A criteria. So the fact that this person might go and do something in 2 hours is often not substantial. Does that make sense? Would you agree with that?
I think so. In capacity assessments, capacity is about how people are at the time. So this is defined in law. This is not a clinical thing. Is what are they able to do in the moment. In assessing someone for risk to harm or risk to hurt someone else or risk to hurt themselves or suicide, we would have what we would call a structured approach to risk assessment. So we would consider about who they are, what their risk of violence is in the future, what things have happened in the past, and we would go through and do that, and then we would make an assessment, is this person at low risk, medium risk, and high risk, and then we would make a determination of whether or not they should stay in the hospital or not, or what safety plan we can put in place. The big caveat is we don't do it very well. And that's not even a radical statement, is that suicide is very rare, relatively speaking. Homicide is very, very rare. And we don't have the ability to develop predictive models about what are actually the risk factors that would lead someone would lead you to go out and shoot your neighbor. Please don't go shoot your neighbor tomorrow. We don't know that. And actually, despite what you hear on the TV or Facebook or analytic, we will actually never be able to predict with any level of clinical certainty about what is going to happen in the future for someone's decision making. So all what we do is we try and do the best we can, and we think about low risk, medium risk, and high risk. And we will, all of us will make mistakes, and all of us have had the experience of having something awful happen after we've made a decision, and it's just part of the world we live in, and it's a terrible thing. I think what tends to be important is that let's just pretend you're in wherever it is that you're working, and Bob comes back from the emergency room, or Sally, or whoever, and you know things aren't getting better, what other resources, or how can you have that story be different? And it's going to be really, really hard. Like, what is actually a community safety plan for that particular person? Recognizing that actually I can't control your behavior. You know, I can only make certain bounded suggestions. But again, also documenting. So the fact that someone goes to the emergency room, and then they're in the emergency room, they're fine, and then they go back to the shelter and they're holding a meat cleaver. They go back to the emergency, go back and forth, and then you just document and document and document. That bit of documenting, it may seem like the most benign procedure, but then on the fourth time that person goes to the emergency room, you know, the picture of the meat cleaver goes with them, as does the documentation that the person there. That will eventually be heard and listened to. I will say, though, this is not what this talk is about at all, but there is a huge disconnect between the forensic psychiatric system and the civil the psychiatric system. Do you know the difference between those two? Is that so? The civil psychiatric system is what we live in. The forensic psychiatric system is essentially when someone has been convicted of an offense, like they've hurt someone or they've stolen something, and they've been found not criminally responsible, and they're under the care of the Ontario Review Board because of mental illness. That's a subset of individuals that has a whole different way of thinking about it. And if you speak to a psychiatrist, we're biased, we would say that a lot more people should be in that forensic system than should be in the civil system, because but if you speak to a civil rights advocate, and I actually think psychiatrists are very into civil rights, but if you speak to they would say, no, we can't have people be in the forensic system because it restricts people's rights tremendously. So there's a lot of individuals who struggle with behavioral regulation, particularly around violence in the context of mental illness, will be involved in mental health diversion programs, which are good. They're very, very good. But we in the civil system don't have the legal mechanisms to actually engage or manage or try and control or have them control their behavior. Whereas those tools, which are much stronger, exist in the forensic psychiatric system.
Well, and with Bob with the meat cleaver, if we're calling him that, I mean, it also, you know, there has to, like, it depends on what his diagnosis is. If his diagnosis is schizophrenia and he's responding to voices in his head and that's why he has a meat cleaver, then that could likely be treated in an inpatient psychiatric unit. If it's antisocial personality disorder and a history of trauma, and that's why he responds when he can't get something, then there's no treatment for that in psychiatry, really. You know, I mean, that's a longer, that's a separate topic. And I think that's where the overlap often happens between the people that people see in the community. We all get a mixed bag. We get a mixed bag of people who's, you know, have primary psychotic disorders that drives their behavior, and people who have trauma or other characterological behaviors, and then a bunch of people in between. I think there was a question over there.
I was just wondering, in situations where
Any narrative that you can tell or share about a client or patient that you're working with, the more complete that is, the more helpful it is. One of the tragedies about community care and also hospital-based care is there's a lot of short-termism, right? People are forced to be discharged after 2 or 3 months or whatever length of time, and that's just not enough for people. I mean, I know certainly when I see people in clinic or at home, the more information I have, it makes it much easier. All what I can say is that one of the best advances that no one has ever talks about in Ontario is about 1.5 years ago, they had this Connecting Ontario thing, so I can look at my office in the computer, the computer in my office, and I can see all the healthcare stuff that's all contact with hospitals and physicians over the last 30 years. But that took a very long time to get set up. It'd be nice if the same thing existed in the community social services world. Maybe it does. I don't know. Yeah.
But I would think it would be relevant if somebody's.
I think it definitely would be, but then again, it goes back to the guy with the meat cleaver, right? Like, what's driving this behavior?
I'm going to say one more thing, and forgive me, it's going to be about home and community care. And that is because it's a challenge for the homeless population and also many of the people who I see. Unlike in cardiology, where if I have a really complicated heart problem, I will go to the fanciest UHN cardiology clinic and people will be so excited to see me and it'll be great, yay. But my clients, my patients who have advanced dementia, who have struggles with their behavior and are challenging, often they're kicked out of shelters or they lose their housing, but then they're actually disqualified from admission to long-term care because they have behaviors, in quotation marks, of a concern. And what it means is that you have quite ill people from a dementia point of view living in the community who really have very little supports or nowhere to go. And until we change that, this is to your point about changing some of the supports for people, that we actually care for we want to care for everyone, but we actually have to prioritize the sickest people and then figure out how to do that. And we don't do that well. I mean, that's often your experience.